our next speaker, Christine Cornelia, from the University of Minnesota, is gonna talk about neuromodulation in pediatric psychiatry. So neuromodulation in pediatric population comes with a whole set of challenges, something we have also started thinking about how to model that.
Well, a thank you to Dr. Opitz for inviting me to speak and for organizing this in the middle of a global pandemic. I appreciate being able to talk. And so today I will be talking about applications of NIBS specifically in pediatric psychiatry. And although I'm the one speaking, I want to acknowledge that my postdoctoral fellow, Sunday Francis, equally contributed to the development of this presentation. NIBS has emerged as a very important tool for investigating the neural mechanisms that underlie psychiatric illness in adults. And it's now TMS or FDA approved for TMS to be used for treatment-resistant depression and OCD. And there's ongoing research to identify ways to optimize NIBS for depression and OCD, as well as research exploring NIBS for other psychiatric disorders, some of which are listed here. And based on the successes of NIBS in advancing our understanding of psychopathology and its treatment, there has been interest in developmentally extending this research down to pediatric populations. And this specific and focused pediatric work is really critical because we know that child psychiatric disorders are not just little adult versions of the illness. So for example, symptomology of particular diagnoses can differ between children and adults. So the specific clinical symptoms they present with for a given diagnosis can differ developmentally. We also know there are differences in the underlying neural circuitry that drives the disorder. And from research on other treatment modalities like medication and therapy, we know that for a given intervention, treatment response can differ across development. And I think NIBS offers us a really unique opportunity in child psychiatry because it provides us a window to intervene and change someone's clinical and functional trajectory early, because many psychiatric disorders do start in childhood. And to date, NIBS has been used to study the following psychiatric disorders in child samples. So depression, which is characterized by persistent depressed mood, Tourette syndrome and other tic disorders, which are characterized by involuntary repetitive motor movements and vocalizations, autism spectrum disorder, which has core features of deficits in social cognition and restrictive repetitive behaviors, attention deficit hyperactivity disorder, ADHD, which is characterized by difficulty focusing, paying attention, as well as hyperactive motor overflow behaviors, and an OCD, which is characterized by repetitive, intrusive thoughts that cause anxiety. These are obsessions, and compulsions, which are ritualized, repetitive behaviors performed in an attempt to reduce obsessional anxiety. And NIBS to date has been used within these diagnostic categories in a couple of ways. So first, it's been used as a tool to probe brain function and dysfunction. So for example, comparing neurophysiological outcomes between patients and healthy controls. And it's also been used to test specific hypotheses about neural mechanisms that drive illness or specific symptoms within a diagnostic category. And second, it's been used as a treatment tool to durably alter brain function. So either as a standalone intervention or in conjunction with cognitive or behavioral therapies. But to date, there's no FDA indication for a child application because we haven't caught up with the level of research that's been done in adults. And in our lab at the University of Minnesota, we are particularly interested in applications of NIBS to neurodevelopmental disorders. And just to ground everyone with what I mean by that term, neurodevelopmental disorders, NDDs, are a class of psychiatric disorders that typically onset during childhood or around the time of puberty. And these disorders have a steady course, so symptoms remain relatively consistent across time rather than having a remitting or relapsing course that we might see in other psychiatric disorders. These disorders are more prevalent in males and feature early neurocognitive deficits. And within our lab, we're particularly interested in 4 NDDs, Tourette syndrome, childhood onset OCD, autism spectrum disorder, and ADHD. And the reason we're interested in these is that they have a very high rate of clinical overlap. So for example, about 80% of people with Tourette syndrome also have ADHD. About 30 to 80% of individuals with ASD have ADHD traits. So there are very clear shared neurocognitive features as well as shared neurobiological and genetic mechanisms. So we believe it's really important to study these disorders in conjunction, because in the clinic, the reality is that most kids are presenting with one or more of these conditions. I'll move to just sharing with you a couple of example studies of neuromodulation that we have done in our lab. And the first is a pilot study. This was published just last week in Brain Stimulation as a case report led by Dr. Sunday Francis. And the intent of this study was to explore if we could use TDCS in conjunction with cognitive training to impact compulsivity. And so compulsivity is a transdiagnostic symptom that we observe across these neurodevelopmental disorders. And compulsivity refers to behaviors that are repetitive and feedback insensitive. So there's sort of these habitual, repetitive behaviors that tend to occur across contexts, and a person continues to perseveratively engage in the behavior despite the kind of feedback or consequences that they might get for that behavior. And so the reason we wanted to target this is because it is common across diagnoses, and because we have a relatively good sense of the neural network that underlies this symptom, and that it's driven by maladaptive activity in orbitofrontal striatal thalamic networks, particularly hypoactivity in the right IFG. So we use TDCS to stimulate right IFG with the anode over right IFG and the cathode over left OFC in two fraternal twins. And so we thought this was sort of a unique case to test this out. It was a double-blind sham-controlled trial. One of the twins received active, the other sham, and they both had multiple neurodevelopmental disorders. They received this TDCS stimulation over 5 days, and the stimulation was paired with cognitive training tasks to enhance the functional targeting of the stimulation. And again, this is a case report, so we have to be tentative about the conclusions, but an important thing we learned was that the stimulation was safe and it was well tolerated within these adolescents. And that is a real concern in child psychiatry, especially because some of these youth have sensory symptoms, so difficulty tolerating uncomfortable sensations, but both of them were able to reasonably well tolerate the sensation of the TDCS stimulation. The parent reported a decrease in compulsivity symptoms and improved quality of life in the teen who received active stimulation, although it's notable that our clinician measured assessment of compulsivity did not show differences between the twins. So again, an early case study, but an interesting example of how we might use stimulation to target transdiagnostic symptoms with known neural circuitry. The second study I want to highlight is a recent project where we assessed the impact of TMS on tic frequencies and urges in youth with Tourette syndrome. And so tics are rapid, repetitive, and movements and vocalizations. So they occur very frequently, multiple times per minute, and they're difficult for people to control. And they have both sensory and motor components. So there's this motor release that happens when the tics actually occur, as well as this sensory buildup. So most people who have tics experience this aversive sensory phenomenon that sort of builds until the tic occurs and then is relieved by tic occurrence. And tics have a relatively well understood underlying neuropathology that involves corticostriatal thalamocortical circuits. And it's thought that tic generation and urge experiences are associated with hyperexcitability in sensory motor loop, particularly hyperexcitability of the supplementary motor area. And I should say that our TMS has been tested as a monotherapy in Tourette's, delivering it over motor cortex, showed null effects, and some mixed outcomes in open label trials for 1 Hertz over SMA. But there are still a lot of questions about what TMS is doing. So we sought to look specifically at how TMS might impact tic frequencies and the urge experience. And so here's the design. We had all of the kids came and did a brain MRI with the goal of using it to do individualized targeting of SMA. So they completed a finger tapping task in the scanner. And then they received either active 1 Hertz rTMS over SMA or sham. And immediately before and after the stimulation, they completed the tic suppression task. And this is a well-validated task. And it's designed to be a direct observation task where youth are in the lab, they're alone in the room, video recorded, and we measure their tics across different instructional conditions. So one being a tic-freely baseline condition where youth are just instructed to let their tics happen naturally, a suppression condition where we ask them to try to stop their tics, and then an enhanced suppression where we reinforce them for doing so. And one important feature of the tic suppression task, and I think of tics more generally that could be of interest to this audience, is it's one of the few neuropsychiatric disorders where we can actually observe the symptoms. So that enables us to do things like videotaped observation and coding to objectively rate changes in symptoms. And that's something that's more difficult to do with less observable symptoms, like, for example, anxiety or mood. So we measured their tics and we had them subjectively rate the intensity of their urges before and after stimulation. And we coded those tapes with raters who were blind to stimulation and the task conditions. And this is just to give you a sense of how we did the individualized targeting. So we used BrainSight to locate the peak bold signal in SMA. So everyone's coil was placed slightly different depending on where we identified peak activation in SMA. And here's a glimpse of, these are the preliminary sort of descriptive data that we have from the study. And what we are generally seeing is that active TMS seems to be associated with a greater reduction in tic frequency during suppression. So this free to tic condition, we didn't really see that the TMS alone was impacting just the baseline rate of symptoms, but it appeared to enhance someone's voluntary ability to suppress. We also see that the active TMS condition seemed to be associated with pretty large decreases in the premonitory urge severity, no matter what kids were doing in the task. So this supports the feasibility of this method to test acute effects of TMS and detect clinically meaningful change. And in our lab, we're particularly interested in moving this towards intervention by pairing TMS with behavioral strategies that are designed to enhance voluntary tic suppression. And one important issue, you've heard about it in other talks, but we've grappled with this a lot in our lab and in these and other studies we do, and something we see very consistently in the psychiatry literature is this issue of variability. So specifically variability and individual differences in terms of the outcomes that we observe. And this heterogeneity of response is really a consistent issue in psychiatry research. So if you look kind of historically and globally at all of the different diagnoses and interventions that we've developed, for a given intervention, what you'll see almost all the time is that it helps about 30 to 60% of patients. So the downside is there's a lot of patients that aren't really benefiting from this one-size-fits-all approach to building new interventions. And so within psychiatry, there is an emerging interest in really leaning into this variability by embracing methods that enable us to more clearly characterize meaningful moderators of treatment so that we can develop more targeted and personalized treatment approaches. And there's a number of factors that can influence response to stimulation, some of which are here. So some are the specific methodologies of coil design or the design of the study, and there are a host of intra-individual factors that can impact stimulation. So including the biological state of the person in terms of what medications they may be taking, their sleep wakefulness, or their hormonal status. We know that ongoing cognitive processes or behavior or emotional state before, during, or after stimulation can also have an impact on its effects. And there are also demographic characteristics that relate to brain anatomy and function that can contribute to outcomes. So to hone in on one of these, given the topic of this meeting, anatomy is one individual variable that we know can significantly impact how the electrical field reaches the desired target. And so we wanted to dig into this variability a little bit in our lab and go back and look at imaging data that we had from kids with psychiatric illness. I'm going to zoom back. Because we suspect that these differences in anatomy are particularly important in pediatric NIBS research. And looking at the literature, there are no published studies to date that explore whether there are differences in electric field models in youth who have psychiatric illness. So that literature has mostly centered on youth with known injury or other anatomical differences. So we wanted to look back at our own data and see if there was variability within these psychiatric populations in individual E-field models. And so the next couple of slides here depict individual E-field models for a sample of youth with Tourette syndrome. On this first slide are models from a group of males with tics. We use the latest version of SimNIBS and T1 scans to model E-field distribution for a figure of 8 coil placed over SMA. So we wanted to hold the constant, the stimulation, to see what kind of variability occurred across the sample. So the coil was placed in the same place for everyone. And what you'll see is there are notable differences in terms of E-field maximal strength and distribution, suggesting there are meaningful individual differences in how these E-fields spread through the brains of these kids. This is also a group of individuals with Tourette, and they're organized so the top row are 15-year-olds, and here are 2 females, and here is a male. And here are 16-year-olds with a female and an age-matched male. And again, you just see that there are these significant individual differences, and this is just one way that we're starting to explore possible sex differences, given that these neurodevelopmental disorders have a clearly known male preponderance, and that we know that stimulation can be impacted by hormonal status or where someone is in their menstrual cycle. So something else for us to just consider. The next couple of slides are models that we did in a sample of 4 youth with OCD. So these were youth who were scanned at baseline before a medication trial. So they were all medication naive. And we used their T1 and T2 scans to simulate figure 8 coil over SMA. So again, the same placement and orientation, just to explore variability. And we again see that in these kids with OCD, there is a variability in individual electric field strength of more than 50% between individuals. We took those same 4 kids with OCD and modeled a TDCS montage, placing the anode over right IFG and the cathode over left OFC. And again, there's this variability with the differences of a factor of 2 across participants. So some implications and future directions I wanted to highlight. So first, I want to underscore the potential promise that I think NIBS holds for child psychiatry as a tool to better understand developmental trajectories of these kids in terms of brain mechanisms, as well as a tool to potentially alter the course of those trajectories towards wellness. I also want to highlight the importance of considering targeting symptoms rather than disorders. So in psychiatry, we have a tendency to want to make treatments for a diagnosis, but there are a lot of problems with that. We know that those disorder categories encompass very heterogeneous groups of individuals, and that within those groups, comorbidity is the rule. So in clinic, it's really rare for us to see a kid who only has one neurodevelopmental disorder. And that's true for other psychiatric illness. So if we really want these treatments to be applicable to a broad range of patients, we have to consider comorbidity as a key area. And we think that targeting symptom-specific treatments might be a wise approach here, because symptom-specific treatments can map onto underlying circuits better and have transdiagnostic benefits. So, for example, thinking back to our approach of targeting circuits underlying compulsivity rather than trying to target circuit deficits that have been seen in OCD. In terms of future directions, again, we saw in our models, and again, this was just an early exploration of individual differences. I think it would be useful to look at these across other psychiatric disorders, but I think it's, I'm probably preaching to the choir in saying that there are going to be these individual differences and that they really matter. And I think they are particularly important for us to consider using to inform stimulation in developmental samples, in psychiatric samples, so not limiting ourselves to individuals that have known structural pathology. And so those individual differences were apparent in both TS and OCD samples. And I think there are ways we can use individualized modeling to help our work. So one could be post hoc to understand variability in response. So that's one thing we're hoping to do is go back, and we didn't have access to StimNIBS in the way we do now when we started the TMS study in Tourette's. So we can go back and use those models to try to understand why some youth might have had a better response than others. And we're also looking forward to using modeling prospectively to individualize stimulation parameters. So using individualized E-field models in kids to make decisions about optimal TMS coil placement and orientation, or TDCS montage. And with that, I want to acknowledge our lab, the CAN lab at the University of Minnesota, in particular, Sunday Francis, who was absolutely instrumental in the data that went into this talk, as well as a number of collaborators we have in and out of the university, and some of our funders. And with that, I'm happy to take any questions.
Thank you, Christine. That was a nice example of how modeling can be used in real practice. And we have one question going to the beginning of your talk when you show a twins study. Can you disclose which neurological disorder the twins had?
Sure, let me go back to that slide. So the first twin had autism, ADHD, anxiety, and OCD. The second had autism, ADHD, anxiety, and compulsive symptoms. So they had relatively similar diagnoses. The difference being that participant 2 didn't meet full diagnostic criteria for OCD. She just had some OCD symptoms.
Thank you. Second question, more on the practical side. How do you communicate the individual variability to the patients and caregivers?
We haven't yet, other than, so the way that we have talked about, for example, the need for doing imaging is to explain to people that we know that everyone's brain is built slightly differently, similar to how the exterior of our body is different across people. And so we aim to use those models in order to identify the optimal way of using TMS to stimulate their brain. And so in lab, we show kids the models of their own brains. A lot of them are very, very excited to see that. So I think we try to just emphasize that we, at this point, don't make anything clinically out of what those models mean. We just use them to inform how we do our research. So I'm guessing that's part of the question is do you communicate clinical relevance? And I would say it's much too early to do anything like that.
Okay, and final question. Do you think that non-invasive brain stimulation can be successfully applied to psychiatric disorders without any reliable biomarker of the illness?
I think it's a great question, and it's a dense one that I think a lot of people are grappling with. And I think we have to also get away from thinking that there is a biomarker for a given illness. This heterogeneity within diagnostic categories is really critical. And so as we're seeing in some of the TMS literature in depression, there's a movement toward away from single protocol TMS to TMS protocols that match patient biotypes. So really thinking about what is the particular circuitry that's driving the symptoms that a given patient is seeing. And I do think it's really critical that we not put the cart before the horse and just start stimulating without that knowledge. And the one other thing I'll add is I think it will also behoove us to be very careful about not over-focusing or not exclusively focusing on neural mechanisms, but to think very carefully about how brain state plays a role in this. And so we know that ongoing cognitive processes or emotional state can have a huge impact in influencing how the brain is situated when it's receiving stimulation. So I think for therapeutic purposes, we also have to think very carefully about how do we control for or optimize ongoing cognitive activity in the context of stimulation so that we're leveraging both stimulation and brain state to achieve improvement for people.